Hello, I'm Dr. Louise Newson. I'm a GP and menopause specialist, and I'm also the founder of the Newson Health Menopause and Wellbeing Centre here in Stratford-upon-Avon. I'm also the founder of the free Balance app. Each week on my podcast, join me and my special guests where we discuss all things perimenopause and menopause. We talk about the latest research, bust myths on menopause symptoms and treatments, and often share moving and always inspirational personal stories. This podcast is brought to you by the Newson Health Group, which has clinics across the UK dedicated to providing individualised perimenopause and menopause care for all women. So today on my podcast, I've got someone I do know very well and I have met in real life, unlike some of my other podcasts. And I've got Professor Mike Kirby, who is an inspiration. He's a real mentor, and more of a mentor than he realises actually for a lot of my work. But I've known him for many years. He is also, like me, very interested in cardiology, cardiovascular disease, disease prevention, keeping healthy, and really interested in looking at people as a whole. He does a lot more maybe with men than women, but he still borders on that line with women's health as well, and works with the British Society of Sexual Medicine, who I've had the privilege of lecturing for many times and lecturing alongside Mike. So I've been lecturing about the role of female hormones, and he's been lecturing a lot about the role of testosterone and men's health. And there is so much crossover. So I'm very honoured to have him here in the podcast. So welcome, Mike, today.
I'm delighted to be here, Louise. I'm a great fan of yours, so I would never say no to you.
Oh, very good. Oh, I've got that on record now, so that's great. So it's really interesting because there's so much misperceptions and in medicine where people have been told something and then there's something else actually, and then they're not really sure, and then they don't want to believe. So even if we start with just testosterone, when you talk about testosterone, people think about male bodybuilders, and that's probably what people will really think. And most of us as clinicians haven't been trained at all about hormones, let alone testosterone in women, which I have talked about quite a lot on previous podcasts, but in men as well. And I remember the first time hearing you lecture, coming to one of the BSSM meetings and thinking, why didn't I know this? Like, why did we not understand the importance of testosterone to improve cardiometabolic health, to reduce risk of heart disease and dementia and osteoporosis in men? And it's still something that's really not spoken about enough, is it?
No, there have been a lot of barriers put up to people using testosterone because in America it was used inappropriately. It was being prescribed there without checking blood levels, just on the basis of a history. And it was being prescribed for bodybuilding. That really got it a very bad reputation. So we tried to overcome that by producing a evidence-based guideline. And the key thing is that it's actually very common to have a low testosterone. And that is driven by the fact that people are changing their lifestyle. So there's more people who are overweight, more men with diabetes. And if you gain central body fat, essentially it produces cytokines or hormones that switch off the control of testosterone in the body. So, for example, men with type 2 diabetes, about 40% of them, if you look, will have a low testosterone.
That's a lot, isn't it?
It's a lot.
40%.
Yeah.
Because I remember years ago, so years ago when I was quite a newly qualified GP, we were asking men with type 2 diabetes, and we were actually measuring their testosterone levels. So we were asking them if they had any symptoms suggestive of testosterone deficiency and measuring their levels. And they mostly, in fact, I think it was probably more than 40%, came back low. And then we were told to stop doing it because it was so common and the system wouldn't actually cope with all the testosterone that needed prescribing. And that was about 20 years ago.
Yes. Yeah, so it takes a long time for evidence to get into practice in medicine. So what the other problem is that the reference ranges are wrong, because when the GPs get the result, there's a very wide reference range from 6 to 30, because if you take blood on 1,000 men, some will be 6, some will be 30, but that doesn't mean that's normal. So we've tried to overcome that by producing action levels. So if the testosterone is 12 and above, that's normal. If it's between 8 and 12, it needs to be repeated, but probably those people might benefit from replacement. If it's less than 8, then they definitely would benefit, because they will be suffering the complications of having low testosterone, which is increased heart disease risk, increased risk of diabetes, loss of muscle, brain fog, etc. So there's a lot of good things you can do. And all we're suggesting is simply replace this hormone back to the normal level it should be in that man. There's nothing special about it. But women need estrogen to stay healthy. Men need testosterone, but they don't need more than normal. They don't need less than normal. They need about right. It's similar between men and women that we do need to get together and sing from the same hymn sheet.
It's exactly the same. I mean, we see lots of women, obviously, with estrogen, progesterone and testosterone deficiency. And I also think about how many men are estrogen and progesterone deficient as well, because that's another conversation. But certainly testosterone deficiency is very common, but a lot of people think they can only take it if they want to build their muscles, like you say, and become some bodybuilder. They don't see it as a treatment that helps reduce risk of diseases. And, like you, Mike, I'm very keen to think about longevity. I want to keep my patients living well and disease-free for as long as possible. And it's more important than it was even, half a century or a century ago, because we're living so much longer. But we only need to look at the rates of osteoporosis, heart disease, diabetes, dementia. They're going off the scale because we're living so much longer. And we have quite inflammatory diets and lifestyles that perhaps we didn't have 40, 50 years ago. So that's compounding. But also when you think about how many people have low hormones, it's quite staggering, isn't it?
No, it really is. And I suppose because we're living longer, it's exaggerated. So for women, from mid-40s to 80 or 90, you're hormone deficient. In men, about 75% of men will maintain their testosterone at normal levels. And about a quarter will become deficient. So it's not the same in men, but it's the same risk on their well-being, really, because having a low testosterone level and having a low estrogen level really affects well-being. It affects sexual function really badly, and loss of muscle, osteoporosis, etc. And it's a big issue, and it's such a simple test to do, and it's a very simple treatment to replace. And there's just been a large randomized controlled trial which has shown that testosterone replacement is perfectly safe from the heart and from the prostate. And those were two barriers that people have put up, saying it causes heart disease and it causes prostate cancer. The Traverse trial, published fairly recently, buries that. It is safe for the heart and it is safe for the prostate.
Which actually makes sense, doesn't it? Because it's a natural hormone. So it'd be very weird to think that it was dangerous in people when you're replacing at physiological levels, which indeed is what happens when you give it to men, isn't it?
Yes, we monitor the blood level and we try and get it in the middle of the normal range. Not too much, not too little.
So it's not difficult medicine.
Well,
so the other area that I've learnt more and more from you, from the British Society of Sexual Medicine, but also from my husband, as you know, Paul, who's a urologist, is about phosphodiesterase inhibitors. So a lot of people will have heard, I think probably everyone has heard of Viagra, but there are other types as well. And I remember again, as quite a young GP, when it first came out, and it's really interesting, and we can talk about what's happened with Viagra now being available over the counter, how commonly prescribed it is. And it's always thought about a drug that's just for erectile dysfunction, that men and only men take for erectile dysfunction. When I talk to people about, hang on, it wasn't actually designed as a drug for erectile dysfunction.
Yeah.
A lot of people don't realise that. They just know the little blue drug that you can buy very easily if you want to have sex. But can we just unpick some of that? Because I think phosphodiesterase inhibitors are as undervalued generally and as hormones, and people don't understand what they are and the potential of how much benefit they could give to people.
I don't think this blog is long enough to talk about all the benefits of PD5 inhibitors, because they are tremendous. It was interesting because with my cardiological hat on, I got very interested in this drug because it was originally used to treat both men and women with coronary artery disease. And it was at the end of the trial that the men refused to give the tablets back. So the research nurse could count them to see how many they'd taken. Whereas the women were handing them back, and in all other studies, men always gave the pills back so they could count and see what had done. And it turned out these men were getting better erections. And because these were patients with underlying cardiovascular disease, about 60 to 70% of those men would have had problems getting an erection. And that really got Pfizer, who were producing Viagra, off on the hunt of the opportunity to make money as a very good drug and a very safe drug for treating erection problems in men. And they forgot that they had a cardiac drug, as did Lilly with tadalafil, as did Bayer with Levitra. So we had 3 companies all doing research studies on erection problems, all showing very positive, very effective drugs at curing erection problems, and they completely forgot. And it was a really missed opportunity. They do work extremely well because they work by relaxing the blood vessels to allow blood to flow effectively into the penis, but they also relax blood vessels everywhere else, like the heart, the legs, the brain, importantly. So what has happened over the last few years, we have found more and more benefits by looking at databases of people taking PD5 inhibitors compared to people who don't. And we published a study where we looked at a very big general practice database of men who had diabetes. And we looked at those men in that practice having PD5 inhibitors, compared them with the same age group of men not taking PD5 inhibitors. And there's about a 30% reduction in cardiovascular death in the men taking them. Quite staggering.
That is a lot.
It is, because the men with erection problems, theoretically, were at the highest risk of dying from heart disease. If you can't get an erection, your heart is headed in the wrong direction. And another study that we did, we went to cardiac rehab units and asked the men if they had erection problems, and 75% did. But less than a quarter had told anybody about it, and they'd had erection problems for 5 years before their heart attack. So by asking about sexual function, you have an opportunity to prevent a heart attack 5 years down the line, because it tells you they've got artery problems, and you give them a statin, treat their blood pressure, treat their diabetes, and you prevent a heart attack. And interestingly enough, a year after we published that diabetes study, there was a group in Sweden where they did the same thing with men with heart disease. Those men with heart disease taking a PD5 inhibitor versus those men without. 50,000 patients in this study. It's big. And they found almost exactly the same figure, about a third reduction in cardiovascular mortality within 3 years of starting to take a PD5 inhibitor. Wow.
Gosh, so 3 years. I mean, that's better than statins and blood pressure
Much
lowering
better,
drugs, isn't
much,
it?
much better. And interestingly enough, the more PD5 inhibitors they took, the better the protection. So if you take it once every couple of weeks, compared with taking it every day, then you didn't do so well. So it seems that
So you're
by
best off taking every day.
regularly, it's best to take it regularly because it is a cardiovascular drug. Actually, at the end of the day, because it improves the lining of the blood vessels, called the endothelium.
Yes.
The vascular endothelium. So ED equals ED. Erection dysfunction equals endothelial dysfunction.
Yeah, and it's interesting because I've talked about endothelium before, which is the lining of our blood vessels, but it's very biologically active, isn't it? And any inflammation in our body will often be reflected in the endothelium. So you get this furring of the arteries, if you like, but you get this build-up of atheroma, plaque, and that's what happens. And like you say, it happens in the penis earlier because the blood supply, the blood vessels are so much thinner than the blood vessels to the heart. So if you've got endothelium, the damage to the endothelium, it will always pick off the finer arteries first. So that's often why people get eye changes before they have blood pressure changes, for example. So that's why ophthalmologists or the opticians spend a long time looking at the back of our eyes, because it's a window into our heart system as well. And actually the phosphodiesterase inhibitors will help with something called nitric oxide as well, won't they? Which is a vasodilator. It opens up the blood vessels and helps to reduce this inflammation as well, which is good for blood pressure as well, isn't it?
Yes, it's very good for blood pressure. I mean, there's a very large meta-analysis where they showed that PD5 inhibitors were protective on cardiovascular health, but also they had beneficial effects on bones, the urogenital tract, the brain. It had benefits on the metabolic profile of the patients taking it, and cardiovascular. So these drugs
it's massive, isn't it?
Widespread implications. The problem is that in the early days, a lot of the studies were preclinical. And of course, these are all off-label indications. So if you want to use them for those indications, then the doctor is prescribing off-label.
But we do that a lot in medicine, don't we? We prescribe a lot of, my daughter has, as you know, chronic migraine, and she's been given anti-epileptic drugs. She's been given different antidepressants for for her migraines. We do it a lot in medicine, but it's still, people often don't realise. But sorry, carry on.
Well, I think for women, you see, women have used Viagra, sildenafil since 2009 because they get treated for pulmonary hypertension. They use a very high dose in pulmonary hypertension, 40 milligrams. And women, of course, are 7 times more likely to get pulmonary hypertension. So, women can take it perfectly safely. And actually, there's no reason why women shouldn't get all the same benefits as the men. There was for example, in 2022, there's a study using it in lower urinary tract symptoms and bladder pain in women. It's very interesting that during the COVID-19 pandemic, the people who were seriously ill with COVID before the vaccination program, both men and women, if they were taking a PD5 inhibitor, they did better. So I think, for women, I think particularly for sexual function, there's 2 large randomized controlled trials showing that women using PD5 inhibitors get benefit with increased arousal, increased ability to orgasm, and I think probably most importantly, more enjoyment out of sex. And, the clitoris, of course, is equally affected by poor blood flow as the penis. You see, with men, when the penis fills with blood, the blood that goes in stays in because the pressure within the penis blocks off the emissary veins, so the blood can't get out. But for women in the clitoris, they don't have that mechanism. It's a constant inflow of blood the whole time. So, in fact, women actually need a better pelvic blood flow than men to some extent. And by improving endothelial function in the clitoral vessels, you improve the perfusion of the clitoris and makes sex much more fun.
Which is not a bad thing. And it's something we were talking before I started recording about how few doctors actually talk about sex to patients who often want to. And it's really, really important. But with this drug, it's more than, I say just in inverted commas because I'm not belittling sex, but it's more than that. You've already said it reduces risk of diseases. And we said at the beginning how common these diseases are as we get older. I spent a lot of time in the 90s and early 2000s as a medical doctor prescribing aspirin for people to reduce risk of heart disease and, especially if they've had a heart attack. And people with diabetes, everybody with type 2 diabetes used to be put on an aspirin as well. And then we realised there were bleeding effects, there were side effects of aspirin. So it's not done as much. But I often think of, everyday phosphodiesterase inhibitor like toldanafil, as a new aspirin, really, without the risks. Is that a fair way to think about it, Mike, or am I being a bit overzealous, do you think?
Aspirin works by stopping the platelets being so sticky, whereas...
But I'm thinking about just not the mechanism, but the just reducing risk of disease.
Works by making the blood vessels more healthy. Certainly in women, there was an Italian study where they used it in ladies with type 2 diabetes, and they got increased... control of the diabetes, and it reduced the inflammatory markers. So I think that's another side to the story, is that unfortunately our lifestyle, if we gain weight, get diabetes, have high blood pressure, we get inflammation of the blood vessels. And that's, I think, one of the ways, in very much the same way that aspirin worked in heart disease, that PDE5 inhibitors work by making the endothelium more healthy and reducing the inflammation. So it's, I think there's lots of data now on prevention of dementia. And how important is that? Jeff and I are just trying to get a randomized controlled trial of tadalafil in patients with severe heart disease, and to look at the dementia data in those patients as well. Because there's good evidence now that taking PDE5 inhibitors reduces your risk of dementia. So that's a bit of an added bonus, isn't it? Less heart disease.
Well, it's a massive...
less urinary symptoms, less dementia, better diabetes control, less Raynaud's disease. And actually, there's good evidence for reduction in colon cancer as well, because PDE5 inhibitors are anti-proliferative. So,
So it beggars the question, doesn't it? Why are more people not taking them? For these reasons. Because anything we can do to reduce risk of diseases will help that individual, but it also, when you're talking about population health and drain on NHS resources, but healthcare systems in any country, we've got to be thinking about keeping people healthy. These drugs are actually quite cheap. They're very low risk. So why are we not prescribing them more, Mike?
Because they're off license for all those indications, and people are very resistant and nervous about prescribing things. I think Viagra got a bit of a bad name, really, because there was a lot of market hype. It got very much associated with sexual problems.
I was reading at the weekend, you probably know this, but one of the ways they wanted to market it when they realised it had this erectile dysfunction benefit was they got blessing from the Pope to say that it would improve relationships in families and it will keep the family unit together. And as soon as they got that endorsement from the Pope, it just opened up. It just made it even easier to market. It has been one of the most most prescribed drugs, as you know, but then quite quickly it became available over the counter. So it's a lot easier for people to get harder to monitor, of course, but people still think, and of course it can be taken for when people want sex, but this is taken as a lower dose often, but every single day.
Yeah.
And that's the shift that I think people haven't realised, that it can be taken every day. It doesn't usually interfere with medication. For most people, don't have contraindications, so it can be used. And I do think about all the other medications that are prescribed, like the antihypertensives, like statins, that don't necessarily have the same long-term benefits that you're describing in very good studies.
Well, I think so. I think the fact it's over the counter is a good thing, because it's A, very difficult to get to see a GP these days. B, a lot of people feel embarrassed, or they think their GP will be embarrassed. And C, that they'd rather be independent and just talk to a pharmacist in a private room. So Viagra's over the counter, tadalafil is over the counter at a dose of 10 milligrams. Viagra's 25 or 50. And I think I flew to Australia for 2 days to advise the Australian government about having Viagra over the counter about 15 years ago. So it didn't become available in Australia actually, but it's been available across Europe over the counter for quite a while now, Poland particularly. And I think that's a good thing, particularly as we know that it has all these other benefits. And if it saves marriages, I think the Pope was right. When I was treating a lot of men, the partner would come in, and part of the problem was the wife would say, well, I think he doesn't love me anymore. I'm not attractive anymore because things aren't working. I would explain it's not actually the fact he doesn't love you anymore or you're not attractive. The problem is that it's the mechanics of the penis are not working because he's had high blood pressure and diabetes. But we can sort this out. There are very few men that we couldn't find a solution to their erection problems. So, we shouldn't just be talking about men or women in isolation. We should be talking about their partnership and really supporting a loving relationship, because I gave a talk the other day about the benefit of continuing to be able to have sex for both men and women. And for women, it gives them about an extra 6 years of life, and for men about the same. And that's probably related to the fact that if you have a good, satisfying, enjoyable sex life, then you're a lot calmer about everything else in your life, and it's a very good form of exercise. It produces oxytocin, which has all sorts of cardiovascular benefits in itself. It's a very under-talked about hormone, because it improves your immune system, it improves blood flow to the brain, it improves heart. So, there are lots of health benefits from being able to continue having a healthy, loving sexual relationship. And unfortunately, a lot of people are deprived of it because they can't get access to the drugs, which is ridiculous because, as you say, they're dead cheap and they're very, very, very safe.
And I play mind games quite a lot, but I often think, I wonder what the world would look like if people who needed hormone replacement, men and women, had the right doses and types for them, and those people that wanted to and were able to take sildenafil or sildenafil, one of the phosphodiesterase inhibitors daily as well, because I think it would reduce a lot of other medications needing to be prescribed. I think people would be happier, of course. We've talked about quality of life, but they would be healthier as well, and there'd be less long-term problems and diseases as well. But we've got a long way to go. I'm quite impatient, as you know, but we have a long way to go before even that's accepted or thought about in traditional medicine.
No, you're right. We need to keep talking about it and waving the flag and showing all the data on safety and efficacy. For men with lower urinary tract symptoms, they often get prescribed finasteride to shrink the prostate, and that has awful sexual side effects.
Absolutely.
They get prescribed alpha blockers, which make them dizzy, and actually the to take daily tadalafil has virtually no side effects. And actually, most of those men also have erection problems, and you're giving them cardiovascular benefit at the same time. So it's quids in really. But I think we have a problem getting GPs to prescribe it for men, but you have a huge problem getting GPs to prescribe it for women.
And you're absolutely right, looking at the lower urinary tract symptoms in women as well. A lot of women are given oxybutynin, which increases risk of dementia. It's not really a nice drug, and even some of the newer drugs still have side effects. So we have a long way to go, Mike, but you are amazing in the way that you educate and share your phenomenal knowledge. So I'm very grateful for you coming today. I always end the podcast with 3 take-home tips. So 3 reasons why people listening to this podcast, whether they're male or female, should know more about phosphodiesterase inhibitors.
Okay, well, they're cheap and safe. They reduce the risk of cardiovascular disease. They are probably one of the most effective treatments for sexual dysfunction in both men and women. And for people with diabetes, they actually improve diabetes control. And if you want an extra one, they could well prevent cancers as well.
Amazing. So, well, I hope this has got people thinking about Viagra and Viagra-like medications, so phosphodiesterase inhibitors, in a different way. So I'm very grateful for your time, and thank you so much.
Oh, it's a pleasure. Thank you for asking me.
You can find out more about Newson Health Group by visiting www.newsonhealth.co.uk. And you can download the free Balance app on the App Store or Google Play.